Okay. Yeah,
Okay.
great.
Do you want to start with our?
Yeah, I'll start out with our learning objectives. Our topic today is unintentional weight loss in the older adult. And we'll go to the objectives, which are understand the workup of the unintentional weight loss, understand the treatment, and know what to do if the workup is negative.
Sounds good.
Take it away, Dr. Birch.
So I have a case. It's a Dr. Jan patient, which I don't know if Dr. Jan actually saw.
So he can deny any problem with treatment plan.
So he's maybe at a disadvantage because I think he was seen by Stephanie, Dr. Windish, and then we kind of got the workup done. So this patient is 60-some years old, mid-60s. He's got like some schizoaffective disorder and sort of has the mentality of a 6-year-old. And he's on some psych medications, but not a lot of other health problems. And he's in a facility in Crete, Nebraska. He has a guardian who is an attorney and has never met the man. And he smokes 1 pack a day for the last 40 years, and so he's in this kind of facility, and he comes in for his annual check, and it turns out that when we talk to him, he's down, his weight is down. He says he has weight loss. And so I guess I thought we could use this to step through what to do.
What you would do.
Yeah.
When
So what do you want?
shows up.
What do you want to do?
Let's
with this
define
guy?
it again.
Good.
So unintentional weight loss is obviously when they're not trying to diet, but they have to lose 5% of their body weight over a period of 6 months to a year.
Mm-hmm.
So that's what it is. It's not a real significant amount. So I think sometimes we miss it. We often look for weight gain because of heart failure, but we often don't look for that small of a weight loss. And if we do, we kind of like, oh, that's good.
Yeah. But we
But
do have elderly people.
In the elderly, it's a different
It's
story.
a different story. When you lose weight, all kinds of I think you do worse.
Yeah.
Thinner people tend to do worse, so it's a serious thing. And what's the first thing that everybody thinks of? Yeah,
Cancer.
Cancer.
Yeah.
And cancer is by far and away the single most common cause, but you're more likely to find another cause. Does that make sense? Mm-hmm. So it's not
Or you're likely to not find anything.
Yeah.
So the majority of patients will not have cancer, in other words. So
yeah.
that come in with that.
Oh shoot, and I forgot, I left out a critical piece of history. The guy had been seen in the emergency room a year before, and I can't remember what the story was on why he was in the emergency room, but he had a thyroid nodule that was identified on ultrasound scanning. So
That's a good clue.
it is a good clue. So what do you guys want to ask him or look for on the chart? Remember, he's got the mentality of a 6-year-old. He has a guardian for a good reason. But you can ask him anything, and what do you guys want to do?
Yeah, so what do you want to do to try to work this up?
Okay, I'm gonna start looking at his medication list just to see if there's any medication that might cause.
That's very good. Medications are really, the last thing you want to do is be the cause of anybody's problem. So yeah, I think that's always a good place to start no matter what. And in weight loss, it's really good. So
We looked at his med list, and actually the meds that he was on were more worried about metabolic side effects because he was on some antipsychotics. There wasn't anything obvious, but I agree. Weight medications, good. What else? Do you guys want to know how much weight he's lost?
Yes.
Yeah.
Good. He can't tell you. And we had the good fortune that he was in the emergency room a year previous.
so you had to wait.
And so we had a weight that we could go on because he couldn't tell us what his weight was. What do you ask the person that doesn't know or you don't have a weight? Maybe that's their presenting complaint.
If their like pants are loose and
Perfect.
stuff like that.
Yeah,
Yeah.
so changing clothes, and you can can be part of your observation in somebody like this. You could see, oh, he's, got the belt notched up and
Yeah.
pants don't fit, and those
Especially in
kinds of
some
things.
of the elderly, you'll see them and their clothes look like they've just hung on them.
Yeah.
They're just draping and
Right.
Pictures can be helpful.
Sure.
I'm shocked. Sometimes I'll have somebody that's a follow-up after a critical illness and you'll see their picture in the Vista imaging and then them in person and you're like, wow.
Yeah.
So we looked on his chart and he had 30 pounds in a year. And so that left him, I think at the visit, his BMI was 23. So what do you guys, what else do you want to ask him?
Any other symptoms? Well, given his history of thyroid nodule, I want to ask if he has palpitations or excessive sweating. I also want to ask about changes in his appetite, mood changes.
Lump in the neck, difficulty swallowing. I'm also gonna focus on GI, like cancers, blood in the stool, or like changing the caliber of the stool itself. And if it's intentional or no, I think it's. But like in his case, it's not gonna be intentional.
Good.
Yeah.
Yeah, so we kind of asked him some of the questions.
Looking for warning signs is still very, very important, because then that can help you, because usually it's not worth spending the money to do a big malignancy workup other than like age-appropriate screening, which in the elderly, often you're past that point. But certainly that's screening, and then once you can find symptoms like blood in the stools, like you mentioned, or something, that helps point you to that. So that's really important.
And if he's young, polyuria, polyphagia, new onset diabetes.
Good, excellent, yeah. And sometimes even the elderly, you get some of these older people, their pancreas kind of just gives up the ghost, and they can lose weight from diabetes.
What I like to think of though is like in elderly, they still get very common diseases with atypical presentation. So cholelithiasis may present, we can find it classic in a healthy person, or like you said, pancreatic insufficiency. So you got to be really careful on your clue hunting, and not you got to really, that's the art. Is where you start like looking at things like, could be an atypical presentation of gallbladder disease or something.
I had one about 2 months ago as a transplant patient, 78, and he came in, all he had was a fever and didn't feel well. And he got admitted to the hospital. He had an impacted gallstone.
Yeah.
His weight was down significantly, and he had positive blood cultures from being, and no belly pain. I examined his belly, and he's a thin little man anyway.
They don't get rigidity or anything either, so it's amazing.
Yeah, so they
related to the decreasing immune system and inflammatory response and things like that. I like to, when I'm thinking about like working somebody up, I like to divide it into 3 things. So I like to look at organic reasons. I like to look at psychiatric reasons, and then I like to look at non-medical reasons, which often people aren't going to tell you, but it's like, I can't afford food, I can't fix dinner anymore. They're afraid of losing their independence, so they're often very reluctant to tell you those things. And so I put them into those 3 pots.
My dentures don't fit because I had a critical illness because I'm elderly.
That's right, because of my weight loss.
Exactly, and then it compounds itself.
Yeah. One thing I found out, I learned from putting together this talk, which I did not know, is that the problems with weight loss, which are pretty bad. I mean, increased morbidity, increased mortality, more falls, more hip fractures, more nursing home placements, besides all the diseases that could be causing it. But intentional weight loss in a frail elderly person can cause just as much morbidity and mortality as unintentional. So I think that's important, and it's important when we counsel our patients on that too. So.
Great. So we asked this guy all the questions, and didn't really have much on review systems at all. Really, he felt fine. His oral cavity is okay. He has access to food.
Yeah, he's in a home.
He's in a home, but it's institutional food. Who's had institutional food?
I think it's everybody on call at the VA has had institutional.
Oh dear, well we're putting it on film, but I'm just going to say it. It's bad. It's terrible.
It's bad.
Yeah. You would lose weight too. But he's been there for years, right? And nothing's really changed.
Although I will say one thing that can change in the elderly, and this is another thing I read, it was kind of funny to me anyway, but they lose their sense of smell and their sense of taste, and so they quit eating, so even if that hasn't changed. But the article said, you lose your hedonistic appetite for food, and I'm like, wow, I never thought about eating ice cream as hedonistic, but sinful. Maybe it is.
It tastes good though.
Exactly.
So flavor enhancers.
Yeah, exactly.
So I got this guy. What do you guys want to do?
Start with basic labs.
Okay. CBC is hemoglobin. Oh, by the way, I'm sorry, I left out some history that you guys asked for. We looked in the chart. He had up-to-date, age-appropriate colon cancer screening. So that was fine. CBC, he's got a new anemia. His hemoglobin's 10.5. It's normocytic.
How old is he, did you say?
64.
Okay.
65-ish, middle 60s.
Okay.
But his colon cancer was only like 2 years ago, and he had like 1 adenomatous polyp.
Okay.
What other labs do you guys want? So CBC with normocytic anemia, 10.5. Previously, when he was in the ER a year earlier, labs were done, and his hemoglobin was 13.
Okay.
So he's got new anemia.
LFTs.
So CMP,
CMP,
the
what
liver
about
function.
Giving
Liver.
a clue.
Oh yeah.
That thyroid nodule.
Everybody wants a TSH. That's the chip, right? You can never be wrong. It's like tuberculosis and amyloid. It's every possible
You're
differential.
right.
No, I say
I'm
those.
gonna write that
I would be
down.
sitting in morning report saying, "Oh, please don't say one because I don't know what it is." But I have these last 3.
That you said every time.
Yeah, and then they would roll their eyes and be like, "You get spared this time." But
That how you got through medical school?
yeah. So the TSH and free T4 were normal, and the thyroid exam similarly was unremarkable, but a thyroid exam can be difficult for a non-endocrinologist. The CMP, the calcium was normal.
Talking about.
However, the LFTs were normal, the electrolytes were normal, but the
Research.
creatinine was now 1.5. A year previous, it was
See
0.8.
how credible that they said the doctors are.
Are there other things that you guys want to get?
Did you say something about calcium?
Calcium was normal. Because that was one that I looked at sort of rapidly.
Yeah.
It's always one,
Does he have other comorbidities, Dr. Burge?
no, just smoking. That's
Okay.
Given his history of smoking, like, and he's older than 55, cancer screening for like lung cancer would be appropriate.
Yeah. I agree.
we did. So we set him up for
That's good age appropriate screening anymore too, right?
And I thought one of the things this could be would be, if not a toxic nodule, maybe thyroid cancer.
Yeah.
So we set him up for repeat ultrasound and the CT. The CT got done, and he had a lytic lesion in his manubrium. Oh, by the way, his total protein was also elevated on the CMP. So, what do you guys want to do?
Best pep.
He's got a big lambda light chain. So what's he got? Yeah, and we biopsied his manubrium, and his manubrium was full of plasma cells, and so that was his.
Yeah.
Or no, wait, I'm sorry, I'm getting confused.
I thought you told me
No, we
about
did.
another patient
We did,
before
yeah,
that.
I did. I'm sorry. No, we did.
But it's a good
No,
patient.
gosh, I'm
This was
thinking.
picked up on the CT.
Yeah, this was picked up
Yeah.
on the CT. He had lymph
There you
nodes that were hidden. I'm sorry. Thank you, Dr. Jan. Old
He
age.
did know.
Old age. If I start losing weight, we're.
Well, the good news is you don't even have to try because intentional weight loss is bad.
Oh boy. I'm sorry. I got two. We had these 2 guys at the same time. This person had lymphadenopathy and in the chest, a very extensive lymphadenopathy, and a PET scan. We did a PET scan that showed a lymph node that was potentially biopsyable up here that we just couldn't feel, but it was kind of behind the sternocleidomastoid. And ultimately, we biopsied it, and he had a low-grade lymphoma. And the reason I thought of this case was the oncologist called me yesterday because I said, this guy's got a low-grade lymphoma. He has a guardian, and it's almost like an ethical question of what do you do. And in low-grade lymphoma, even in somebody without the social circumstances, you only treat if you have symptoms. And he said, how convinced are you that the weight loss is from the malignancy? And I said, I'm not 100%, but so the plan is to see him back, and we'll do a good evaluation on him for weight loss. But if he continues to lose weight, or if we are pretty sure he's got symptoms, they'll line him up for some Rituxan treatment. So I said, this is very timely.
It is very timely.
So,
I think looking at remember that weight loss is kind of a sign of severity of existing disease. So like COPD and
yes.
those other kinds of things can certainly be a cause. So just understanding what their other comorbidities are. I think in the workup you can include an HIV and look at those kinds of things as well. It was interesting there hasn't been a lot of studies about unintentional weight loss, but in the small study that I found, anybody with normal screening lab, like your CBC and your TSH and your CMP, did not have a malignancy. So you don't have to be going to spending all this amount of screening and things. Oh, and I think they had a CRP in there too. So anybody with normal lab for that did not have that. But other things we should do is like screen for depression.
Depression's very common.
Yeah.
Yeah. So ask good questions.
We mentioned medication, so. And then I guess we want to get into treatment a little bit.
Yeah, I like
Are we
the generic
missing-
treatment.
Yeah.
I had a guy yesterday, I met with him and his daughter, and he's losing weight. He's 86 on dialysis. And he doesn't have good access to food, he can't prepare food, and
It doesn't taste good when he does.
yeah, and he's been trying to follow this renal diabetic diet.
Oh, yeah.
So we just said, you're
Eat what you like.
86. Use some salt. How
Yeah.
often do you recommend that? But
That's nice.
Yeah, institutional food is bad. And,
Mm-hmm.
and then, what do you guys think about? So we're internists. We love to prescribe medicine. Sometimes too much medicine. So what medicines are out there? Yeah, I was gonna ask. I heard from the Monday crew that Dr. Silverstein, the oncologist, likes it and feels that it works well. But I've only used it a few times and not had good success. But I don't.
What is it for?
Megace.
Megace.
Yeah. I haven't had much luck,
I
but of
used
course
to use it a lot more, and now I don't use it much anymore.
I remember
I
using
didn't have a lot of good results.
HIV sometimes,
Mhm.
or frank AIDS, but you know, the oncologist, at least one of them seems to be a believer, but
Right.
they see a lot more of it in that setting. But I worry because it's a hormone and you are at risk for thrombosis. It seemed like it caused nausea.
Yeah, might make
Um,
things worse.
What else do we have in our bucket?
Mirtazapine for
Mirtazapine.
elderly with depression and
Yeah, I like it
weight
when there's
loss.
coexisting depression or sleep issues and things like that. Using it for that, I have used that pretty well.
I've had mixed results.
Mhm.
Better luck, I think, than with the
Right.
Remeron than the hormone medicine.
what
But
about medical marijuana.
Oh, good. That's next. Oh, the mirtazapine, real quick. What should you be careful with in the elderly?
It's dizzy.
Yeah, it can cause orthostatic.
Sedation,
Yeah, sedation,
falls.
falls, and orthostatic hypotension.
Right.
So, and generally speaking, the lower doses help more with sleep and appetite. As you get into larger doses, it tends to be more antidepressant, and those effects that are desirable for these things become less.
Yeah.
So I usually start with a very small dose and don't taper it if that's what don't titrate up, sorry.
Medical marijuana.
I have one guy that I prescribe it to and he gets outside of the
No,
VA.
you're talking Marinol though.
Marinol, sorry.
Yeah.
Medical marijuana, I don't know what. They had a review article in the New England Journal within the last 2 years, and I was so excited. I sat down and I was like, "Oh boy, I'm finally gonna be able to answer all these people ask me questions," and just basically said there's no studies,
I know. You know,
or no studies worth anything.
I probably shouldn't say this on film, but since it's still illegal in Nebraska,
Mhm.
but even if it works by placebo effect, I don't care. You know,
Yeah.
I don't view marijuana any worse than I do like liquor. But you still got to worry about sedation and those other kinds of things. And certainly I hate prescribing anything that you have to smoke. The Marinol is extremely expensive. I've tried it a few times. It didn't work.
That's been my.
Okay.
I don't even know if this guy's taking it. He's kind of working in my suspicion, which is I have not asked him because partly I don't want to know the answer, is I think that he takes it so that he has a reason to have a positive drug screen.
Oh, he's covering up real marijuana use.
That's my suspicion.
Wow, that's clever. I would never think of that.
Because I call in like it's a controlled substance and you know it's not he says his appetite is bad and he does have some medical conditions and
His appetite's bad because his narcotics are slowing his gut down.
he's not on narcotics, otherwise I would have refused.
Okay.
But you know, it doesn't.
We digress.
I don't renew it very often. But so the Marinol, I agree. I've used it probably 4 or 5 times. I'm unimpressed with the results.
I will say the article says though that you want to go with non-medication for the first 3 months. So say you've worked somebody up and you really haven't found a cause, or maybe they have something like COPD and so he's already optimized treatment. You go 3 months without treating them and then you reassess them. And I have to say, I think a dietitian consult is almost mandatory. They do so much better than we do at helping the patients and following up. It's like a physical therapy consult or a pharmacy consult for insulin titration. I think it's really important. Otherwise, I don't think we're doing them justice by giving them a handout or something. And they're going to find out better than us that they can't get to food or they can't afford it and those kinds of things.
It really takes a detail.
Yeah.
And this is also where a family member and sometimes the V&A are like gold,
Right.
especially in the elderly, because they'll give you a better picture of what's really going on.
Right.
That person's not going to come in and be like, I can't make my own food because
Right. No, they're not going to admit it.
yeah, it's not going to happen.
Yeah. All right, should we go
Yeah.
with our, oh no. Oh,
Oh,
for
rats.
heaven's sakes, do you mind if I just read them?
Sure.
This means we talk too long.
Yeah, for sure.
Okay, so our key points are weight loss increases morbidity and mortality. Non-malignant causes are more common than malignant. If your initial history and physical and workup is negative, neoplasm is very unlikely. So you don't need to go spend a lot of money on a workup, and you want to reassess in 3 months. Non-medical treatment should be trialed first, and weight loss is a marker of coexisting disease severity.
Agreed. Okay.
All right.